Blair O'Neill. I'm an interventional cardiologist from Edmonton, Alberta, Canada. Help yourself, Nina, you said, my wife's beckoning, so somebody else had that inspiration, started a low-carb diet, 23 pounds to the better. After a lifetime of working out, I just couldn't keep up with it. I'm getting older, as you can tell from my hair color. Anyway, I know, where you're coming from and believe that story and know you've been attacked viciously and unkindly. But, Salim Yusuf, and I don't know if anybody has seen that, he is a good Canadian out of Hamilton, loves to debunk hypotheses, and just presented results from the PURE study, something like 24-country, 100,000 patients in a registry, clearly showing an association cardiovascular and total mortality reduction with increased saturated fat intake. Once you get above 45 to 50%, surprise, carbohydrate intake, cardiovascular mortality goes up, and protective effect with a Mediterranean diet with oligo-saturated fat. So, it seemed to me when I saw Salim, who I respect, who currently is the World Heart Federation president, that we must be hitting a tipping point finally. Do you really think so? And, how do we push us to the top of the mountain and get us to where we need to go? Because I preached this for a long time and have been wrong and realize now how I need to help my patients. So curious, all of you, how you feel about that.
I'll just respond a little bit to the Yusuf Salim, who is actually the past president of the World Heart Federation, and he's the #2 most cited medical scientist in the world, I'm told. And he said his #1 conclusion from his study is that saturated fats do not cause heart disease, and so he is going to publish his results soon, I think. But are we at a tipping point? I think that what we need to do is there's just there's been books, there's been articles. There's some people who say we need more science. I think one of my takeaways is we have got the science. We just need to pay attention to it. The science has been done. We just need to stop suppressing and ignoring the science. And then the other thing I think that it needs to happen is that the tremendous amount of energy that exists for low carb and all of the MDs and PhDs who understand that science we need to just sort of organize and advocate. I spent a little time in Washington, D.C. talking to policymakers, and one thing I realized was they had never heard from, I was like the first person that most of them had ever heard from a different story, because they just haven't had, nobody's gone to their offices to tell them this story, except for the Atkins company. So we need to organize and have our voices heard, have the science heard, is my view. Anybody else?
Yeah. A couple of hopeful things. I think one of them is the massive groundswell from ordinary people that I discovered in diabetes.co.uk. When it comes to a point that 185,000 people it is now can be bothered to do a 10-week online course, when that was just one thing that we did, and there's others as well. When that number of people are finding this works, if the doctors don't wake up to some of the truths of this, we're going to look like we've got our trousers down, really. We will lose credibility if we don't. And the new democracy as a democratization of medicine is beginning to happen in surgeries everywhere, and that patients are teaching doctors things. And I think that's a new factor. I found it to be a new factor. The second thing I would just say, I don't know whether you've heard of Dr. Scott Murray, a young cardiologist. Well, he's president of the British Association of Preventative Cardiology, and I know he's really low carb. So that's somebody at the top in the UK now, a young guy. There's a conference coming up and he's got me speaking. So that's something, isn't it, when an old GP is speaking to all the cardiologists in London. Thank you.
Oh, hi. I just wanted to say thank you, everybody, for really inspirational talks today. But my question's for you, Nina. I was at the ADA and the EASD conferences last year, and I scoured the programs to look for research that was being presented about low-carb diets, and I didn't see anything. There was nothing there. There were 30,000 doctors combined at these two meetings, and I was just horrified. And it's really interesting to hear you talking about how this research is being suppressed and silenced. So I just wonder, what can be done about that? How can we get this research out there? What are researchers doing to try and get their voice and their research papers heard?
That's a good question. I think that really don't actually know the answer. I know that it is getting harder and harder to suppress this data as there is more and more and more of it. And in some emails that I obtained through a Freedom of Information Act request of the dietary guidelines, the expert committee, their deliberations, and when they were looking, they actually did do a literature review of the low-carb diet, and then they decided they were going to put that whole review in the methodology section of the report, where it totally does not belong. And one of the dietary guideline committee members said, I don't think we should be burying it there. It's quite a sizable body of literature. So it just gets harder and harder. It's the science, the body of science is bigger and louder. It's starting to get, there are now NIH funded some studies on low carb, and I think eventually, hopefully it'll be heard. But again, I think it goes back to some advocacy work, like getting some just hardcore advocacy, getting it out there, getting it to the politicians, getting it to the policymakers, and our voices have not been represented.
Just another point. Is Jason still here? Well, I should point out that our very own Jason Fung is editor of Insulin Resistance, so that if anybody had something they wanted to publish, Insulin Resistance published my last work without very much difficulty, and it's peer-reviewed. So we have there a journal that we should use.
Yeah, but what happened, I'm sorry, but to respond to that, what happens is that those articles are published in journals that the mainstream nutritionists won't read, and they won't cite them, and they ignore them. And there was an excellent paper out about low carb as the best and first treatment for diabetes by Richard Feynman and 20 other authors, or some huge number of other authors, and it is almost never cited. It's just not been considered. So when I went through the list of what the tactics are, these tactics of ignore, silence, that remains a tactic, I think, that is used.
I agree. The only thing is that publication in a peer-reviewed journal that's what helped me within the Royal College, exactly that kind of thing. So I'm now an expert clinical advisor to the Royal College of General Practitioners, and that happened because I've been published. So these are the initial steps, getting published, the initial steps towards respectability and being accepted. And the other GPs, because I have works that have been published, do listen to me in a way that they wouldn't. Nobody would have listened to me at all without a single publication. So I think it is worthwhile, though nobody cites me very much, but it's a start. It's a start.
I was going to say, I've cited that Feynman paper in 2 different papers that I've written. So
good for you.
I think it's just a case of there are a huge number of scientists and MDs who are getting these results. And one thing that I am slightly frustrated by, just because it's difficult, and some people, as a doctor, say you don't necessarily have the experience of publishing your data. But if we encourage people to publish this data, and that's one of the main things that I'm a real advocate for, is if you have data where you've done something and your patients improve, you should publish it. And there is always somewhere you can publish it. And just as the body of data increases, it will, like I said, it is baby steps, like David says, but I do think we will get there eventually.
Eric Westman, Durham, North Carolina. This is back to the clinical treatment of diabetes. The work at diabetes.co.uk and that you do in the clinic is impressive, and the teaching of sugar as in teaspoons of sugar is fantastic. We use a variation of that and add on that if you calculate out the amount of sugar in the bloodstream at a given moment, and in fact I do this to visiting professors and endocrinologists in particular, and ask them how many grams of sugar is there in the bloodstream. You have to tell them they're 5 liters or 7 because they won't remember. And the only people I've had who've been able to do that are these 2 Japanese medical students who knew just like that. So it's a teaspoon of sugar in the bloodstream at any given moment. I wonder, now my question, in your teaching, how many teaspoons of sugar can an individual have? And do you limit it, or on the other hand, when you ask people what they're eating, what do they end up having in terms of grams of carbohydrate?
That's a brilliant question. It brings out something rather important. I try not to tell patients what to do, really. I try and give them information, and then they...
Is this a British thing?
No, perhaps it is, I don't know. And because if we are too prescriptive, the danger of being prescriptive is that there are as many different low-carb diets as there are people in the room or people on... We all interpret it differently, and the more prescriptive I am, the more likely I am to fail. It's far better that patients understand the rules and interpret those rules in their own lives and budgets and families, and then it seems to go better. So I'm often asked, how many grams of carbohydrate do I advise my patients? I don't. I never advise grams of anything or weighing anything. I give them an A4 sheet with information, and then we talk about their steps, because they're often on a sort of sugar spectrum, and they'll take a first step, so that the first step might be to give up added sugar. And if their life is cured by that, well, great. If not, we have to go to the next stage. So that's a slightly lengthy reply, but I just find it works so much better that I don't prescribe particularly grams, that I just encourage them to move along the spectrum towards fewer refined carbs.
And so, and then internet information, Charlotte, do you know how many grams of carbs people are eating?
Yeah, so we've carried that same message across to the program. We're not trying to be prescriptive, and on the basis that we want to be scalable and give as many people access to this idea as possible. And so we start with kind of indicating that you should maybe have a smaller portion, so we use a plate method initially, and then as you progress through the program, we're giving people the tools that as they want to, and if it's right for them, they can reduce their carbohydrates further. And that's on the basis that when we've surveyed people before we started the program, people were having on average 300 grams of carbohydrates a day, and some people were having upwards of 500 grams because they were just so unaware of the impact that it was having. And so kind of just starting at that, reducing it a little bit, and then empowering that patient to make their own choices and make their own decisions for what's right for them. That's kind of what we've worked out is the best. And on average, people end the program because we've asked them around 90 grams of carbohydrates. But again, it's not prescriptive, and kind of it's up to what people do. And some people on the program go as far as 20 grams or less. So it's completely variable to what suits them and their families.
Great. Thank you so much.
Ben Bickman, scientist. Maryanne, Tommy, of all the talks, and I loved them all, yours is the one that was, unfortunately for me, the only one I really understood, which is laughable, right? Maryanne, can I ask 3 questions? Maybe if we're quick, Tommy. First one, I love it. Metabolic endotoxemia, LPS, that's my background. How do we reconcile, in your mind, the fact that in the human studies, because it's just hard to appreciate the rodent studies, in the human studies where there is increased LPS in the plasma, yet on the low-carb, high-fat diets, publications have shown reductions in PAI, TNF-alpha, interleukin-1 beta. So to me, if it's relevant that LPS would be up in the blood, but it's hard for me to interpret it as too meaningful when we don't see demonstrable markers increase in the plasma. What do you think about that?
I think that's a great question, and I was talking to Zoe about this briefly, and part of it is that I think for people who don't respond to a low carbohydrate diet, there's a certain set of things that have to align in terms of initial gut health plus gut microbiota plus the diet itself. And we know that weight loss improves both gut integrity and improves the gut microbiota. And we also know that if you're removing inflammatory carbohydrates or other parts of the diet, you're also going to see an improvement in inflammation, like you mentioned. So I think in general, going on a low carbohydrate diet will improve all of those parameters. But I think particularly because we cannot measure that response in most, using standard markers, I think there is a a subset of people where those things align to cause a problem, but because of the other benefits of a low carbohydrate diet, you'll actually mitigate some of those main problems.
Yeah. Okay. Last one. Thank you. In those same studies where they're giving the person cream, do you remember? I don't. Did the control group get a similarly caloric load from a carbohydrate source? Because as you mentioned rightly, LPS is everywhere. It's on our hands, the utensils, the air we're breathing on, microparticles. Do you know, did they look at an equal caloric load from carbohydrate?
As far as I remember, it wasn't based, so it wasn't a caloric load based on body weight. So I think it was a fixed amount of cream, and I think it was 75 grams of fat, if I remember correctly. But so it wasn't adjusted to body weight.
But
so
did they have like a control group that had if that 75 grams of cream was just say 1,000 calories? I don't know.
Yeah.
Did they have 1,000 calorie carb shake as a control? Do you know? I don't.
No,
remember.
they didn't do that. They didn't do that control comparison. But there are a number of studies where they've done some similar things, and if you use fructose, then you also see an increase in endotoxemia compared to glucose.
Yep, that's right.
And I think there's potential for so I think cheesecake is probably like the absolute worst possible combination. But in that particular study, I don't think they did a calorically matched non-fat meal, if I remember correctly.
Yeah. Okay. Great. Well, we can talk more later. Thanks very much.
Hi, Angela Doucette from Prince Edward Island, Canada. Thank you so much for all your sharing and experience and knowledge. In Canada, we had recently a letter sent to Health Canada signed by 200-odd physicians and other health professionals, one of which is from my hometown. And when she knew that I was coming here, she had asked, as a GP, if I could bring back some advice or some direction, or, how could she start incorporating some of, especially what Dr. Unwin's done in his practice, and kind of starting to introduce this to her patients.
So you're wondering how GPs could make a start?
Mm-hmm. And I guess she's looking for kind of more something to back her up, as far as evidence and.
Right. I think the first thing. So I've gone to a lot of trouble to prepare a sort of health professionals low carb pack that includes all the evidence that I can find and encourages them with diet sheets and everything, so that if anybody this is a health professional, emails me at home at unwin5@btinternet.com and asks me for my health professionals guide, they shall have it.
I will pass that along to her. Thank you.
So that's got all sorts of things in there to just encourage them. I think if you wanted a first step, just the idea of asking patients, so you've got a problem with sugar now. There are golden opportunities, clinical golden opportunities, and they exist. When you first tell somebody they have type 2 diabetes, they're very receptive to you. When you first say they've got pre-diabetes, patients are very interested. And so I call these kind of golden opportunities time to really discuss with the patient what they're hoping for. So that the first idea is that look out for golden opportunities, and at that time, ask your patient, are you interested in seriously reducing sugar as the first step? Because for many patients, that's all they would need to do if they would do that. And if somebody respected, like a GP, says, I believe this could make a big difference. Exactly. That's the most, belief is so important. I didn't have belief for the first 25 years. I just thought nothing makes much difference. They just seem to get fatter and iller. And I just give you drugs and hope you go away. That's a terrible, awful thing. It's because I didn't have belief. But when I had belief that this was serious, I could make a difference, then the patients seemed to take more notice of me. So that if doctors could signal to patients that they have choice, patients can make a big difference to the outcomes. That's really important. And are you up for change before we start medication? So will that do? Is that all right?
That's all right. Thank you so much.
Can I just add a word to that notion of belief, which I think is powerful, and I think one of the things that the general population struggles with is just the overwhelming message that all diets are equally, you fail equally at all diets. I mean, I think every 3 weeks there's 4,000 words in the New York Times about how all diets fail equally badly, and it creates, I think, I don't think that's done on purpose, but the effect is to make people feel hopeless, and to feel like all diets, they will fail on diets, and so and the effect is to say, so then you must move on to drugs and surgery or whatever else there is. So this, getting across this message that this is a diet that is supported by an enormous body of clinical trial research, really more than any other diet out there, and to try to somehow convey that sense of hope and confidence in it.
A supplementary to that. So I started as the first doctor in the practice low carb, but now 5 or 6 of the doctors are low carb, both practice nurses, the practice manager, and 3 of the receptionists, because they watched. So we can all lead by example. I've been low carb, properly low carb, for 4 years. I don't mind who knows.
Hi, I had a question on gut health. You had mentioned probiotics as being effective, but I was wondering, in your practice, have you found any herbs or like teas or anything like that is good on a routine basis that'll improve gut health?
I think you should probably start with testing. There's some interesting data on probiotics where they gave, I think it was VSL3 or something very similar, and gave it during an overfeeding study, and it actually prevented the increase in endotoxemia during overfeeding. And probiotics just tend to be transient in the gut. They don't necessarily colonize, but they help sort of shift things along. But we do often start with herbal supplements, but it will definitely depend on. We test, and then we look at the sensitivities of what's there, and then there are various combinations of herbs that we use rather than sort of focusing on a single thing. But so we start by testing rather than just using anything empirically.
Mm-hmm. Very good, thank you.
Okay, next question. Hello. So I was wondering, I like to read scientific journals and learn more about keto. I'm afraid it's going to fall. That would be bad. All right. So where would I go to look at more research, to look at, read these studies? Because as we've heard, the studies sometimes don't get out or they're silenced or what have you. So where do I go? How can I read more?
We've both got pages on our site.
Citations
Yeah, I have a page on my site, zoeharcombe.com. There's a sort of drop down with academic studies, and I've just tried to capture, over the past, I think, 3 years, academic studies challenging the current dietary guidelines advice. And Nina's got something on the Nutrition Coalition, particularly on the saturated fat. So mine is sort of any aspect of the dietary guidelines that have been challenged. I've put it on that list. And Nina's got a great list on saturated fat studies that have really shaken things up. So, 2 good starts.
Yeah, no, I think there's also, somebody might help me remember this, but somebody has a really excellent ketogenic resources Ellen Davis has an excellent website with resources and lists of studies there.
And Sam's actually as well. Sorry, yeah, Sam Feltham, I don't know if you know, you were in Sam's talk this morning. Sam has been keeping a list of RCTs with low carb versus low fat, and I think he's up to 55 now, he said this morning. And of the statistically significant ones, 28 win on the low carb side and none win on the low fat side. And he's got the non-statistically significant results, and it's just laid out so well. So he's got the Excel spreadsheet for you. It will tell you the calories in this arm of the study, the calories in the other, so you can see if it was isocaloric, or you can see if there was actually an advantage. In some cases, they're eating more calories on the low carb, but they're doing better than the low fat diet. So that's a great resource as well.
Yeah, I'm sorry. Just to have one more thing. There's sort of 2 purposes for gathering information. One is to have it to take to your doctor or take to your colleagues, or use it to try to convince other people. And there are all these resources from David Unwin, what he's put together, and what Sam Feltham has put together. And the other thing is to learn for yourself if you want to do the diet. Sort of how-tos. There's dietdoctor.com is a great resource for that. And who am I missing? But anyway, there's a lot of how-tos out there.
I was just going to say, if you're on Facebook, then there are a number of a huge number of groups where they focus on the research and put up a number of studies that you can go to. One that first springs to mind is Marty Kendall's one, Optimizing Nutrition, if you're part of that. Lots of studies go in there from randomized control trials, but also some more mechanistic stuff. And if you're feeling really geeky, then I definitely recommend the lower insulin group run by Gabor Adosi and some of his friends, where your mind will dribble out of your ears after spending some time there. But that's definitely worth it too.
Perfect. Thank you.
We'll just grab this question over here.
Hi, my name is Sloan. I'm from Richmond, Virginia. Thank you all for speaking today. Tommy, my question is for you. Can you recommend any good labs to test for your gut bacteria?
So I think the tests that we do, we get run on most people. We do a doctor's data, a comprehensive stool analysis with parasitology, which runs over 3 days. We also do the Diagnostic Solutions GI map. We've just added that, which is a PCR-based test, and the other one's a culture-based test. Previously, particularly if you're worried about parasites or something, we've used a BioHealth 401H, but we've now switched over to the GI map for most people. So that's those. Then you cover culturomics and some PCR data, and that sort of will give you a good snapshot.
Yeah, thank you.
Your question?
Hi. Yeah, thank you for all of your professional work. It's just changed so many lives. And with all of the studies that we're talking about, how and when does that make it into medical textbooks so that our biology classes mention it? And I mean, I went back to school. I'm in my basic biology class, which has probably been years for you guys, but you know, it doesn't even hardly, like, there's this much about fat metabolism. It is this much about sugar, and it's like nobody understands it, you know, the kids were, you know, but anyway, how do you get the medical textbooks written and changed so that everybody learns different?
I'm just going to offer one response, and there are probably other doctors here who might have another one, but I really believe, having studied now this system for some time, is that it really all comes from the dietary guidelines. The dietary guideline, the professional societies, the American Medical Association, the Diabetes Association, all those, and those are the associations that kind of dictate curricula. They all refer back to the dietary guidelines. The dietary guidelines is like their backstop, and they adopt all of their recommendations. And so I think that until you somehow you have to go to like the Death Star and alter that, because it really is a top-down system from what I see.
Does anyone else want to answer? No?
Can I add to that, please? No. You write the textbooks. So there are two I want to make you aware of. One called Ketogenic Diet and Metabolic Therapies, edited by Susan Massino. And that one just came out this last fall. And then there's another one that I helped to edit called Obesity Evaluation and Treatment Essentials. And in both those books, there are chapters on using ketogenic diets for diabetes or obesity treatment in general, and the basic biochemistry of low-carb diets. But we write the textbooks. That's how it changes, right?
I was also going to say that there is definitely scope for a bottom-up approach, and I know, so David's talking about doctors who want to work with him. I'm frequently contacted by medical students, both in the US and the UK, who want to learn more about different ways of doing things. When I was teaching physiology to medical students in Norway during my PhD, I definitely told them the real version rather than the diet's guideline version, and nobody was there to stop me. So I think it has to come up from the bottom too. So if you are a physician or any kind of educator, just like I know that Richard Feynman, when he teaches his biochemistry students, he teaches, why a low carbohydrate diet is better for the, treatment of metabolic disease. So people are doing it. Again, I think there's sort of this current groundswell and will hopefully sort of take over eventually.
Okay, we'll take that question.
Thank you for your work. I've been a family practitioner for 20 years, and like this good doctor from the UK, the last 20 years have been extremely frustrating, to the point it was painful to step in the exam room with a diabetic because there was nothing more to offer than more pills. For the last 14 months, I've been a true believer, and I have well over 100 of my patients on low-carb diets and having tremendous results because of your work, and I'm very grateful. As I try and share the light with my colleagues, I find that their first concern is not for the patient, which tells you the environment in American medicine. Their first concern is for their license. I would love to hear your feedback about your thoughts on the litigious atmosphere in United States medicine and how that trumps science and how even science is trumping science. And if there are any safeguards for me as I present this to my endocrinologist, to whom I used to refer and no longer do, and my cardiologist, who I no longer refer to treat these things because I'm finding my success is much better with theirs than theirs.
Thank you. Thank you so much for that. There's a few things in there. The first thing is just to point out that the British NICE guidelines, just rewritten December 2015 for diabetes, type 2 diabetes, say that we should encourage low glycemic index sources of carbohydrate for patients with type 2 diabetes. So I see that isn't American guidelines, but nevertheless it is the British NICE guidelines, supposedly evidence-based, and I found that very reassuring, and partly why I talk so much about the glycemic index. The next thing is I worry about when we talk keto because we frighten colleagues with this. So I've learnt when I had to begin with my own partnership to say lower carb first, and that frightens people less, the words lower carb, because actually an awful lot of doctors mix up keto with ketoacidosis. Lots of them do, and particularly nurses, and you can get threats from that. And then when you have the successes, I always try and demonstrate to the partners, the doctors that I work with, I gather data. So any of us that do well, it's always worth gathering the data. If you've got 100 patients, you're in a really good position to do a case series there, and you'll get some wonderful results. If you could publish that, then your partners start really taking you seriously, because you might be the only one in the partnership publishing anything at all.
So, Zoe, how do doctors avoid becoming the next Tim Noakes?
How do doctors avoid becoming the next Tim Noakes? I think we have to ask for the evidence back, because we're being challenged on, what's the evidence on low-carb diets. An instrumental moment for me was when I was presenting with Dr. John Briffa. I don't know how many people know Dr. John Briffa. And we presented at a conference, and a classically trained bariatric surgeon who believed all the cholesterol theory and everything else stood up and effectively wanted to say to the audience, please don't believe anything you've just heard, because, this is all going to kill you, this ignoring cholesterol nonsense, don't worry about fat. And I got a lesson that day from Dr. John Briffa, because instead of defending our position, he attacked back. So he said to this person who stood up and grabbed the microphone and accused us of almost mass murder, where is your evidence? You say that cholesterol is going to cause heart disease. Where is your evidence? And they see it as such an accepted fact. It's as Nina said, the science is settled. The idea that you actually challenge them back and say, where is that evidence? They seem quite astonished, and they don't have it to hand. And I would encourage everybody in this audience, because you will be challenged by loved ones. We hear mother-in-laws are accusing women of trying to kill their husbands because they put them on bacon and eggs for breakfast or whatever. So I learned the Briffa approach at this conference. So I no longer defend. Somebody says to me, all this is complete nonsense. I attack. And you don't attack nastily, just ask a question. So I mean, Sam did it brilliantly once. He was on a BBC 5 programme in the UK, and the presenter actually asked him a question that, was, surely this raises saturated fat, cholesterol or whatever. And he just went back to her and said, so how does that work? And she was just completely stopped in her tracks because nobody had said, so how does that fat cholesterol thing work? But we've got to do it, and you will watch the other person crumble because they don't even know where to go for the evidence. We're the ones looking for the evidence because we're the ones challenging the current status quo. The status quo people think the science is settled. So just ask questions of everyone, and they stop fighting you because then they go off into their own little rabbit hole. So I don't know if that's quite answered the what can you do to avoid being sued, but challenge back when fellow doctors are saying, is this safe or whatever? Well, where do your dietary guidelines come from? And see if they can answer that.
Okay, we've got time for one more very quick question.
I was just going to add to how to go about so it doesn't happen to me again.
Again.
First of all, everyone lead by example. You cannot argue doctor by doctor when you're setting the example in your own practice. I'm completely in agreement, Zoe, and Belinda's told me I'm too aggressive, but I get challenged on that all the time. And the one question which undermines the entire medical profession, I say, well, what's cholesterol? And 99% of doctors cannot answer it. And immediately, the rug's been pulled out from underneath. And not how cholesterol gives trouble, I just say, what's cholesterol? And, we might talk about it at another time because there are 3 things that it does. But it literally undermines the whole thing. That's a great first one. And the other one is, you really seriously think God made the brain dependent on one fuel source called glucose? Was God that stupid to allow us to be dependent on one? So, I mean, the 2 little words that I use with the medical profession, with dietitians, I'm not trying to be nasty. I just say, you seriously believe that? Because that's, those steps going forward. Yes, everyone's worried about and I'll mention this, on Sunday, we can't wait for the guidelines to change because those health guidelines have been written by the industry. So if it's good enough for you to do this for your own care and you to then advise that to your patients, then stand by your patients and stand up and say, I believe in this. And the proof is out there. Thank you.
Just another point about keeping us all safe. I mean, really, one of the basic reasons for involving patients in decision making is they're less likely to sue you later.
Very good point. On that note, we'll have to wrap up. And in the interest of time, please give one more round of applause to our speakers.